Recently, the Society for Vascular Surgery decided to put together a video archive of distinguished vascular surgeons, both in leadership roles and also innovators in the field, and also decided to include people who are honorary members of the SVS. And today we have with us Jean-Pierre Becquemin, a distinguished French surgeon who is visiting in Chicago for the SVS meeting. And welcome. Welcome to Chicago.
Thank you.
Yeah.
It's my pleasure.
For how many years have you been coming to the SVS meetings?
Oh, for many years. I was always admiring the work which is done by this country. And despite the fact that in France, probably the very first vascular surgeons were French,
That's right.
The leadership has been taken by American surgeons for some years, and now I like to come to United States to the SVS meeting, particularly because we can share a lot of things from different continents, and so.
Most of your training was in France, but you've also done some training outside of France.
Well, most of my training was in France because I'm not so young, and at that time it was very difficult to travel, to get money, to be involved in different institutions and so on. But I traveled a lot in the last 15 years maybe, and had the chance to spend 6 months in Sydney with Jim May's team, and it was very important for me to share, because it was in year 2000, and I started doing endovascular things in 1994. I was among the first academic vascular surgeon to do an endovascular repair. That costed me a lot of trouble in France.
1994 was very early.
Yeah, very early. It was very early. And it was with Claude Mial who invented the first stentor graft, and nobody believed in the technology at that time. And then after some times I wonder, well, maybe I'm wrong doing that. And I needed to share what I was thinking with different people. So I had the opportunity to go to Australia to visit Jim May and ask him, well, Jim, what do you think? Are we wrong or not? And he said, well, that's the future of repair of AAA. And he was right.
He was certainly right about that, yes. You know, we usually start out with these interviews asking people about where they were raised, you know, what part of the country they were raised in, and so forth, and about their parents a little bit.
Yeah. Okay, I was born in the Île-de-France area, which is surrounding Paris, and Fontainebleau. Fontainebleau is famous because that where the first king, François Ier, built a castle. And then it was also famous because Napoleon, when he lost the battle against the Brit, the Waterloo battle, it's amazing because the Waterloo battle, the anniversary, 200 years anniversary was yesterday or the day before?
Yesterday, it happened. It's a long time.
200 years ago. And then Fontainebleau is a very nice city and in the forest, and so I spent there all my young times.
Norman Rich wrote me, emailed me, say he cannot come because of Waterloo battle. I don't know what the relationship, but he mentioned it.
Is that right?
Yeah.
So that, for me, it's amazing if you look at things, because since I was raised in this area, there's a lot of rocks in the forest, nothing to do with vascular surgery. But I started doing some sport and some climbing, rock climbing, and then I was very like mountaineering and so on. And when I started my residency in vascular surgery, I learned that one of the very first vascular surgeons in France was Jacques Coudot. And Jacques Coudot was also a climber. And he accompanied the French expedition to the Annapurna in 1952 or 3 or something like that. So it was amazing to share the same passion of sports and also jobs and vascular surgery.
And then you knew Udo, did you meet him? Or?
No, because he died from a car accident in probably in 1955, something like that. So
Yeah.
a little bit younger.
Yeah. So then, where did you go to college?
College was in Fontainebleau, and then my medical school was in Paris. So there was one medical school at that time, and after 1969, they were separated in different university, and then I made my residency and everything in Créteil, where I'm still working, by the way.
Who were the mentors that persuaded you or inspired you to go into surgery?
Probably you won't know him, but Didier Mélière was the chief of general surgery at that time in Créteil, but he liked vascular surgery, and he met Udo, by the way, from some reason, and then I like the way of treating patient by repairing something, not just removing organs, but try to save legs and so on, and life and so on. And then afterwards, I work with Charles Dubost and Alain Carpentier, which were famous cardiac surgeon. But Charles Dubost did the first successful open repair for AAA. So
you worked with him?
I worked with him.
Oh, yeah.
I used to work with him. Yes.
When you were a trainee?
Yeah.
Yeah, I see. Oh yeah.
And I asked him, what do you feel of me? And he said, well, you're good. You're a nice guy, and I would love to do cardiac surgery. So, well, you better choose vascular surgery. And it was a very good advice, because, as you know, the number of cardiac operation is probably a little bit declining, and vascular surgery is improving and enlarging the number of cases and innovation too. So.
Yeah, I think many of us are glad that we went into vascular instead of cardiac surgery.
Yeah,
that's
sure.
right. So was Dubost doing cardiac and vascular when you knew him?
No, mostly cardiac.
He was doing mostly cardiac.
Yeah.
Yeah.
Mostly cardiac. But then, you know, in terms of technique and technicity and so on, I think for trainees it's very useful to have some knowledge in cardiac surgery, even if you do only peripheral cases, and especially now that we are going to the arch and so on. So it's good to know how to do that.
Are there anything you'd like to say about him? I mean, he's a famous person in the history of vascular surgery.
Yeah,
certainly.
Yeah. He was a great guy. Difficult, but great guy.
He's difficult, but a great guy.
Yeah.
Was he doing infrarenal aortas back when you knew him?
Yes, some, but the majority of his cases were cardiac cases. I've seen some aortic repair, yes, but the majority was cardiac surgery. Then during my trainees, I met different people like Jean Nathalie, who was the chief of the Pitié-Salpêtrière of the vascular surgery department at that time, and also Jean-Michel Cormier. There was a
Cormier. I've met Cormier.
Yeah, those two guys. They were, well, when I was a trainee, the gods of vascular surgery. You know, that was the big guys, and so I trained with Cormier a little bit. I did not the chance to work with Jean Nathalie, but well, we have a good relationship. So,
you were saying that some of the most famous important vascular surgeons were French. René Lariche, for example, is someone that we always talk about, and you probably heard about him secondhand in your training.
Even if Lariche was sometimes, obviously, he's famous, and he was a leader at that time, but he had probably this conception of a sympathectomy, which probably was wrong, but anyway, and everybody made mistakes. So.
Yeah, well, he was thinking about it at least. And DeBakey came and spent time with Lariche. And,
it's true.
There's the International Society of Surgery gives a René Lariche award periodically. Yeah. And this year, Jim Yao is going to get the René Lariche award in Bangkok. Yes, yeah. So it's he's certainly a famous person in vascular surgery history. Yeah. And so then did you do a formal period of training in vascular surgery?
Well,
Or was it part of the general surgery training?
well, when it changed when I was at the end of my training, because before I was certified, it was vascular surgery was not recognized as a full specialty. It just was part of the or cardiac or general surgery, and there was a big fight at that time. And then Jean-Nathalie and my boss Didier Mélière just succeeded in creating the vascular surgery certification. It was in 1980 something, 1 or 2, I don't remember. And then since I finished my training at that time, I just had the first exam of vascular surgery, a national exam, which has succeeded. And so that was the change at that time. And now the...
So it was right when you finished the training that they had
Exactly.
the first exam, and that's about the time that the first exam was given here too.
Exactly.
Yeah, right.
And now it's in France. It's very well organized, and the vascular training. There are you have to do. There are programs where you have to do some operation and to follow courses and training and so on. And there is an examination at the end, and you are or not certified. And then if you are certified, you can go on the work market. And, which that means that it's very well controlled, and that the people who are trained in France now are, most of them are good surgeons.
How many finish every year in the training scheme?
Well, I do think it's around between 20, 25 people. Maybe
25. We finish about 115,
Yeah.
115 in the United
Yeah.
States every year, so 25.
Probably it's not enough, because the population is growing older, and then there are many, as is in country, many diabetic patients, and so we probably need a little bit more.
And then what did you find about vascular surgery that really appealed to you, that made you decide to do that instead of biliary tract or thoracic surgery?
Well, again, it's well. To tell the truth, I was a little bit afraid of blood. So, I wanted to master that. And then putting clamp, you control the bleeding, and that's it. So I don't know it's a real reason, but that's probably one of the reasons. And then I like the way of, again, reconstructing arteries and doing repair, and not just removing organs and so on. So, wow. And I think also the specialty is very nice, because you have to know every part of the human body, from the neck to the thorax, to the abdomen, to the legs, so you can travel in the body, and it's very exciting. So, and you also, I think what is important about vascular surgery is there is a medical side of it. It's just not technique. It's also, you have to assess how patient, what is his disease, he will he support the operation or not, and there is you have to think about the best treatment for the patient, and I think it's very stimulating to do not only technique but also assessing the patient risk factors and so on.
When you finished with your training in the early 1980s, were you doing tibial bypasses? Lots of them, lots of tibial bypasses.
I spent days and nights doing distal bypass, but I love it, because at that time there was a question of reverse or in situ bypass. We did some study on that, and well, it was wow.
They both worked very well.
Yeah, exactly.
Yeah.
But they almost disappeared.
Yeah.
We almost don't do any of them now.
Yeah. Right.
And what we did, so we started carotid artery surgery also. There was also a competition with a neurosurgeon of the institutions, and then aneurysm and so on.
So back in those days, what were your favorite operations to do before we started doing so much endo?
Well, distal bypass was a good operation, and at least, if I'm honest about carotid surgery, I love carotid surgery, but in terms of service rendu, as we say in French, probably it's better to have a successful limb bypass than a carotid surgery because you save more legs and brain damage if you look at the statistics, especially for the asymptomatic carotid stenosis. So, well, I love carotid, I love bypass, what I love most is the thoracoabdominal repair because it's so exciting. So, for the surgeon, maybe less for the patient.
Right, and we really don't do very many thoracoabdominal aneurysms anymore.
Yeah.
That's right. Yeah, that's interesting.
Yeah, and there are not so many patients. I was surprised to have the figures because we had a trial which was conducted in France, which is called the Windows trial, which was published in Annals of Surgery last year, and we had the national figures of patients treated for thoracoabdominal aneurysm. There were not so many, probably less than 100 per year. So
100 patients.
Yes, operated
for thoracoabdominal aneurysms done in the traditional way.
Yeah, and half of them by fenestrated and branch graft.
Oh, I see. So, yeah.
But at that time, the graft were not reimbursed, so there was a limitation. Probably it will increase a little bit. But there are not so many. That's why I think that it will be useful for in terms of healthcare that this operation has to be centralized by people who know how to do them.
So, quite a long time ago, you got started with the course that you have, the controversies meeting, really.
Yeah.
And, I mean, that was in 1992.
Exactly.
So it's quite a few years ago now.
Yeah.
How did you decide to get that going?
Well, you know, back in the 19th, you have the big guys at conference who say, well, I do 1,000 cases this way, you don't know how to do that, and that's the way it is. And there was no much of a debate. So, and I was thinking, well, maybe he's right, but maybe not. So I was thinking that starting what I call controversies and what a better way to improve knowledge about the disease, the technique, and so on. So we started that in 1992. I was at that time. I used to be the secretary of French vascular surgery. So I organized a meeting for 3 years, and then, well, I learned how to organize meetings. So I started my own meeting, and it was quite successful and grow. 4 years from when we started. There were probably 400 people, and now there are 1,500 people every year, so which is good.
Yeah, that's great. Yeah. What about the impact of those meetings? You know, the major meetings have a very important role in vascular surgery. Frank Feith's meeting.
Sure. I think that are a big impact because. Well, obviously, you share experience. So you may agree, disagree, but you still share experience. And each time I go to a meeting, I learn sometimes little things, but it may change my practice. And I love going to meetings and come back to my office and saying, well, I will do the things differently. And then you share. There are things which have been said on the podium, but also all the things which are said in the lobby, and probably they are almost all as important as on the podium because you know the reality and well, I think it's important. Maybe there are too many meetings because there are many meetings everywhere in the world, but well.
Yeah, there's great value to besides the very scientific meetings like this where things go to be published, to have meetings that are less formal where you can talk about brand new things.
Yeah, I agree.
Yeah.
I agree. And in terms of meeting, in my view, I'm sure you share that, there are two types of meetings. There are meetings where you show some scientific research which are done by residents or young trainees, and they have to start and to give talk. And there are meetings where you ask the key opinion leaders, and that probably different level of knowledge. So both of them are important.
Sometimes I feel that the organization of international vascular isn't very strong, as it is in other fields, where there's a very organized international committee that has meetings on a regular basis and people get together.
I think international meetings are important because you see a different way of different practice around the world, and there may be different things to learn. But well, I'm a little bit not confused, but I feel a mixed feeling about that, because when you go to international meeting, the level of knowledge may be a little bit different.
That's true.
And the level of delivering a message also is different. So sometimes you pick up good things in international meeting, but I must say I probably prefer national meeting, because you know about the level and
so the value of all the information may not be as high.
Exactly.
Yeah. Tell us about the practice of vascular surgery in France, as it compares to what interventional radiologists do and the cardiac surgeons do and the cardiologists do.
So I think in France, vascular surgeons are relatively lucky, because the competition is not that strong as it is in United States, for example, where you have the cardiologist or who are doing carotid and so on. In France, very few cardiologists do carotid stenting.
Oh, I see.
They don't dare to do that. Some, but very few. And radiologists, it's amazing to see that in recent years there are less and less interventional radiologists. They prefer to do classic radiology or treating cancer patients, but they are less and less involved in vascular disease. That means that the market is open for vascular surgery. And since we learned to do all these endovascular things years ago, and the training is very good, I think the majority of the cases are in the hands of vascular surgeons, which is good. And what else? I know that in Germany or in Switzerland, for example, there are people coming from other specialty, medical specialty, who are doing angioplasty, peripheral angioplasty, and so on. That's not the case in France. So I think competition is important, but when you have to, I think if a patient comes to the institution, take the right door, he has an endo procedure, the left door, he has an open procedure, it's wrong. It's really wrong. You have to do the best.
You want the best procedure, whatever is best for the person.
So if one people is doing both, well, there's no fight, so no problem of any type. So
you do many EVARs and TVARs and endovascular aortic operations. What are you going to do in the future? What are your goals for the future? What are you going to work on?
Well, I think that there has been a dramatic change in the way we are treating patients for the last 10 years, and now in my institution, probably about 90% of the people treated for aneurysm are treated by stent graft, with some success.
I think 90% in our practice too, in my practice. Right?
Yeah, sure. I think people are looking for that, and I think it's lighter operation and progress. We have seen progress in the last 2 years. Graft has improved a lot. They are smaller size, and so you don't need to open the groin. We do almost all our cases with a percutaneous technique. And also anesthesiology has improved a lot. And now in our practice, we do majority of the cases under some local, and then we started the program with hypnosis. And I was
with what?
Hypnosis.
Oh, with hypnosis.
You know.
Is that right?
It's really amazing, but it's worked very well, and then it changed everything, because the patient recover very rapidly. They are not submitted to anesthesiological drug and so on. So the following day they are leaving and they're okay. So So that the way slowly and slowly the treatment are improving and well, so
Does the hypnosis allow you to puncture the groin without without local anesthetic?
well, we do some
Yeah,
because
yeah.
you can puncture with the wire and the introducer sheath, but then when you introduce a larger sheath, then the patient may feel some pain in the groin. And also one drawback of hypnosis is that the patient can move because he's conscious. So,
Yeah.
so if you have a difficult cases with a short neck and you are ready to deliver the graft and then the patient moves, that's a bad thing. So, but what I think it's amazing.
Do you perform the hypnosis yourself?
No. No, I don't do that.
Yeah, an expert has to come. Yeah,
You cannot do everything.
that's right.
You have to choose.
Yeah.
So the future, what could be the future for triple treatment? Probably, I don't know, but maybe gene therapy, or I don't know. But it will be the end of surgery, which is sad.
Well, we have a long way to go with aortic surgery,
Yeah.
with complicated aortic surgery, to
Yeah,
make
right.
even the most complicated cases relatively easy to do. We're still a long way from there.
Yeah, I agree.
Yeah.
I agree.
Yeah. What about dissection in France? How do you manage dissection?
That's a matter of debate, as you
Yeah.
know. So, well, we try to have centers where dissection are referred, because there are a lot of discussion about who should be treated, who should not. So, our approach is to, we have a good relationship with the cardiac surgeon. So, they are the type A dissection that take care of, but all the type B are, they show the patient and we decide what to do. Either medical treatment when they are uncomplicated, not too large dissection, and but also we put some stent graft. But there are many questions. How long the stent should be? Should we cover the entire aorta and increase the risk of paraplegia, or just cover the entry tier and so on? So it's a matter of research. So.
Yeah, the uncomplicated ones are quite debatable, aren't they?
Yeah, they are, because I have some patients I follow for 10 years with no complications, but sometimes you have about 30 or 40% of the patients in whom the aorta enlarged, so you have to do something. And probably in chronic phases, it's more difficult to treat than in acute phases when the flap is still mobile and treatable.
Welcome to Chicago.
Thank
I
you.
hope you enjoy the meeting.
Very much.
You mentioned Dr. Lattery and Cormier. I had the honor to meet them before. That was some time ago. That proved that you have a very good training with the two
It was two pioneers.
very famous French surgeons. I still remember the book that Cormier wrote. That was a very, very good vascular surgery book.
But you know, Doctor, at that time we had no choice, because they were the only one to practice vascular surgery. So you had to train with them.
If you wanted to do it. Yeah.
But it was great guys.
We don't know too much about the training of vascular surgeon in France. Can you tell us a little bit how you guys train them? How many years? What they had to go through?
Wow. Okay. So there are the trainees. They have to have when they choose surgery. There are 1 or 2 years to decide which specialty they will practice. That could be vascular surgery or thoracic surgery or general surgery and so on. And then they have to choose. Once they have chosen, they have to train for 4 semesters as a junior resident, and then afterwards they have to spend 2 more years as a senior resident, and then afterwards they have to pass the exam of the college, and then generally they succeed because they are well trained, and then they can go to practice either at the university hospital or most of them in the private practice. So I think that the training in France is very good, as I said, because well, people they are very well looked after. So and they are very dedicated. I think that the younger one, that they are very good, very good.
Would it be, is it 5 years then of surgical training?
That it's
Total?
five
By the
6
time
years on total.
it's 6 years by the
Yeah.
time you finish. 6 years. All right.
Yeah. Long time. Could be more, but generally speaking, 6 years.
Now, in your interview that you sent me, you mentioned about the female MD suddenly quit and then create a manpower problem. Can you tell us more about
Yes.
the reason is because in America, more female are going into surgery. Are we facing the same thing that you are going to have?
Yeah, I agree.
Could you tell us more about that?
Yes, what I see as a teacher at the university, that about 80% of the students are ladies. So it's not a surprise that when they come at the end of their medical school, some of them will go to surgery. So there are more and more ladies in surgery, which is a problem. Not because they are very good, very clever, but then they will have a second life, so which could be the first life. So probably the manpower could be a problem in the future. I don't know, but we have to hire probably more people than we have now. And it's already true for the general practitioners. In France, we are missing general practitioners because nobody wants to go in certain part of France, and they call the medical desert. Nobody, no doctors. And the government try to find incentive to send the GP to these places, but they refuse. Because the small cities are almost ghost cities, you know. Everybody lives. They want to be in big cities, so that's a problem. And to come back to surgery, I feel that may be a problem in the future. It's not a question of quality and experience and so on, because the ladies they are very good, but still in terms of hours and of practice and so on. When you have to raise baby and take care of the husband, which generally goes now to the finance sectors rather than to surgery.
One of the, not concern, one of the thing I always feel, America and France, we like to have more exchange.
Yeah.
Do you have any suggestion how we should do better? Now, the Society for Vascular Surgery have the international membership.
Yeah, I know.
Have an international scholar. Would you support that? Or?
Yeah, I support it very, very much. Yes. One of the problem used to be the language, because for people of my age, very few were comfortable with their English. But it's changing because there are more exchanges, and in my own institution, I love to send trainees in United States or Great Britain to join the lab. One of the problems we face is that they are not allowed to scrub. You know, the young guys, as we were, we love to treat patients, to be in the OR, and that. Probably one of the limitations that we have to think about to overcome that, and the exchanges will be probably more fruitful.
Yep. Currently, to scrub, you have to pass the 3 levels of the exam, which is hard and time-consuming.
Yeah, I know that.
The USMLE exams before you can scrub.
But I don't know. I'm not a politician, but probably there could be some way of. Offering some position to people outside of United States to work with you in the clinical practice, because that's what they are looking for. They're not looking to operate rats or rabbits and so on. They prefer to do the clinical work. So I don't know if it's possible or not. I know the problem of litigation and so on, and insurance and so on, but that's something you may have to think about.
In Europe, you have the common market.
Yeah.
You finish training, you have to take the examination for certification. Is that can you operate in Germany?
Yes, even without the European certifications, because you can go in Europe. If you are in the EU, you can work at least on the paper. You can work everywhere in Europe. After that, you know that there are different constraints, and such as you have to have the positions. But we know, for example, people from Holland, they are hired in Germany, but there are question of language and so on, because it's not just English. You have to speak German if you want to go to Germany, or Italian if you want to go to Italy. But
how about in England? Can you go to England and do surgery?
England. Well, I know. Yes, we can. Yeah, I'm aware of one of a surgeon who was trained in Paris and is working in London.
Yeah.
By the way, there's a very good position there, but he's a very clever guy.
Yeah.
So it's possible.
Okay.
So could an American resident come to France and then scrub?
Yeah.
Yeah.
Yes,
So
because
it's different than it would be the other way around.
yeah, and the system is a little bit different because American have a Japanese guys who was trained, and I had him as the associate professor of vascular surgery. So when he came in my institution, he was not really allowed to scrub. But then I went to the manager of the hospital and say, well, this guy, he knows how to do the operation, so you have to allow him to scrub. And I said, okay, it's your responsibility as the head of the department. Yeah. If you are confident, trust him, okay. But if there is some problems, it's your fault, my fault.
Oh, yeah.
So I said, okay, he can scrub. So it's possible. Probably it's a little bit less rigid than in United States for different reasons.
One of the frequent questions we ask is, what would you tell the young surgeon? What would be your advice?
Wow. Love life, love vascular surgery is a great job, and I've done that for 40 years, and I'm still fascinated by this job. And so, well, you have to be enthusiastic about what you are doing, and then do the best for your patients, and try to be well honest with yourself and the patient you have to take care of, and well.
You're here in Chicago presenting a paper.
Yeah. Oh, it's very difficult to have a paper accepted here. Every year I send some abstract, but some of them are rejected, but that okay. And this year we were fortunate, one of my senior trainees has sent a paper, a work we have done on hypogastric preservation during EVAR. And we compare two techniques. One is the iliac branch device, and the other one was the gimlet technique for the hypogastric preservation. So we had, it's a small study, but it showed the trends and some drawback of one technique compared to the other.
Yeah, that's very interesting, because that's evolving technology,
exactly.
isn't it? Yeah,
Exactly.
yes. Yeah. Tell us about your family.
Well, I have a relatively big family, four children. Some are very grown up, and my daughter is working art and design. My eldest son is working for a French company in India, and he's very successful. And my second son is working for an American company, which is very famous because it's Google.
Oh, it's Google. Right.
But he is working with a Paris subsidiary, and the younger one is 16. Is want to be a professional handball player. So we'll see what happens. But he's still young. And none of them wanted to go to medicine, and that's one of my regrets.
Do you, what hobbies do you have, or sports and hobbies that you're interested in?
Well, sports, that was climbing, mountaineering, and I love that. I did crazy things when I was young, and like climbing steep rocks, and going to Himalaya. I try to climb the 8,000 meters summit. I failed, but because I was not strong enough. But that was adventure, and I loved it at that time. But now, well, you know, I cannot do that anymore. But I like hiking. Every summertime we go to the mountains and with a backpack and spend some time there. That is my main sport hobby. So otherwise, I love playing piano. I'm not very good. It's not just for myself, but I think it's relaxing. Think of different things and do, well, maybe half an hour, 1 hour every night, and that's good. It's good. I've heard that to be a good surgeon, you have to learn piano. All right.
Well, listen, thank you very much for coming to be with us.
Thank you.
We really enjoyed interviewing you.
Thank you very much.